Okay, welcome back. This will be the last session of the conference, and it's been a wonderful experience. The last session is on changes in healthcare utilization during COVID-19. And like many things, it's unpaid bill that's come due. Um, we didn't have the surge capacity to maintain normal healthcare. So now we're seeing the problems of lack of early screening and all sorts of side effects. So we have three marvelous speakers. Our first speaker is Dr. Cameron Kaplan of the University of South California, and he will speak on adapting to disruption, changes in colorectal cancer screening modalities and disparities during the COVID-19 pandemic. Dr. Kaplan?
What do I do here to get the slides on here? Oh, I guess I see the.
Yeah.
Okay.
It's all set. We just have to, we're ready to share his screen. Oh. What do we do?
Got it. All right. Cool. Thanks, everybody. So I took some of the advice from lunch and I went into my time machine back in time, and I decided that, I would share kind of just the high level stuff and just share a bunch of pictures for the most part, because most of the stuff I'm doing is like pretty simple, descriptive stuff. Here is a picture of all the people on my team. Very nice. And yeah, so just sort of as background, we've talked a lot about the pandemic as a disruptor, and it really profoundly altered access to routine services. So the grant that my grant is mostly focused on this, understanding the effect of the pandemic on access to primary care, preventive care, routine screening, things like that. And so what I'm going to be sharing today is a bit about the effect on cancer screening, and specifically on colorectal cancer screening, because there's some interesting things that that happen in colorectal cancer screening. And so we can kind of think of colorectal cancer screening as having two different modalities. They're sort of equally recommended by most of the groups that recommend cancer screening for people who are 45 and older, or it sort of depends slightly based on which guidelines you're looking at. But the two options, the two modalities, are essentially invasive procedures. Most, I'll be saying colonoscopy. There technically are some other things you could do, including sigmoidoscopy or a CT, which is sort of a virtual colonoscopy. But they all kind of require being in person, doing some prep work and being under sedation. And then there's sort of the non-invasive procedures, and I'll be sort of referring to this as FIT tests, but there technically are other ones such as FOBT and the FIT DNA or Cologuard. But essentially, you could do those as an alternative, and you would need to screen every year. And if you screen positive, then you would need to get a colonoscopy. So one of the interesting things to think about is, how did the use of these different tools get changed during the pandemic, given that, using these sort of non-invasive procedures may have been preferred in order to mitigate some of the risk of COVID, and may have been preferred to by patients given their potential perceived risk of COVID. Another kind of interesting thing, just because I'm also going to be talking about some of the racial and ethnic disparities, is that there are like kind of pre-existing racial and ethnic disparities in the use of these tests. So first of all, FIT tests tend to be more used in sort of managed care populations, whereas fee for service, you tend to see a little bit more colonoscopy. But the other thing is that you tend to see FIT tests more commonly used among Hispanic and Asian adults compared to non-Hispanic whites. Some of that may have to do with like regional differences, but I think that also it has to do with like the types of health systems that people go to. Colonoscopies are more commonly used among non-Hispanic white adults. So the data for this study, actually, the data I'm going to be showing you is almost entirely, or is entirely from the Optum Clinformatics data mart. This is national commercial claims data, nationwide commercial claims data. It's not a nationally representative sample, but it does have plans in every state. We're also using data in other studies, and it's a little bit messier, and so that's why I'm not going to show it today, especially regarding the colorectal cancer screening. But we have data from our Los Angeles County DHS system. This is 4 safety net hospitals in LA County and 24 outpatient clinics. And I mean, I'll just sort of mention that because we're finding a lot of the same things when we're looking at breast cancer screening in the LA County data. It's a little bit harder to get at colorectal cancer screening, partly because the strategy in the safety net population is to do FIT only, and they don't do colonoscopy as screening, except in some rare circumstances. And because of the way that the data comes from the EHR, it's a little bit harder to identify the FIT test than the colonoscopy. So we do look at that with breast cancer, but I'll sort of mention that at the end. So just, briefly the methods, I'm just going to show you a bunch of pictures, but we kind of do these group level monthly predicted probabilities, so sort of an event study type thing. Using linear probability models, we adjust for demographic variables. Basically, this is just age, sex, comorbidities, and then geographic location. And in the Optum data, we're only able to see census regions. And then we sort of look at, okay, let's just look at pre-pandemic and post-pandemic, and we sort of take out this middle point. And you can kind of see in the data that there's a very clear middle point where everything drops off. We kind of exclude that part and just look at, okay, well, how does it look in the pre-period versus the post-period? And we look at people aged 40 to 75 with continuous enrollment in the 12 months prior to the screening index month. So just to look at, and so you can see here where we're sort of breaking out the pre-pandemic and post-pandemic when we're looking at the sort of difference, if you will, models. And this is just looking at, first of all, what was the use of these different modalities? So in the light blue, you see colonoscopy, and in the darker blue, I guess, you see FIT tests. And what you can see is, essentially, first of all, during this like acute pandemic phase, there was like a slightly less or a noticeably less drop off in FIT tests, but after returning, then you don't really see this increase in the use of FIT tests, which we may have predicted, given that like this may have been an opportunity to increase use of these sort of non-invasive procedures. So, and in fact, what you kind of see is that the discrepancy between colonoscopy and FIT tests actually increases. So there's actually relatively less FIT tests. There's like, I mean, the number of these that are done is about equal, but remember that you only have to do a colonoscopy every 10 years. So in reality, like most people are complying with the guidelines through colonoscopy still. So one thing we wanted to think about is like, who is getting these different tests? So if we look at like maybe thinking about COVID risk mitigation, we might think that people with more comorbidities or who are older, we also did some similar thing for age, are more likely to be or less likely to get colonoscopy in the like kind of post-pandemic or the non-acute pandemic phase. And what we see is that actually in this like pre-pandemic phase, there's a big gap between people who have more comorbidities or one or more comorbidities versus 0. And in that post-pandemic phase, that kind of decreases a little bit. So we look at that, using a diff and diff model, just looking at people with comorbidities versus not comorbidities, you can see that there is a statistically significant decrease here. So relatively speaking, people with one or more comorbidities are less likely to get colonoscopies. So now I want to say, well, did those people get FIT tests instead? And the answer is no. The people with more comorbidities did not get more FIT tests relative to the pre-pandemic period. And you also see a statistically significant decline there. So in overall, people with comorbidities are less likely to get screened for colorectal cancer in the post-pandemic period. So we don't really see this like, shift towards, people getting different tests as a result of the pandemic. We also looked at this by race and ethnicity, and here this is just any colorectal cancer screening. So so there's a little bit, it's a little bit difficult in the data because the guidelines are to get a test every 10 years. You can't really come up with a very good measure of like whether or not someone is compliant with the guidelines because you'd have to go back 10 years of data. But what we can see is like, if you look by race and ethnicity, Hispanic adults have the highest rates of getting screened in any given month. That doesn't necessarily mean that they have the highest compliance because they're more likely to get fit tests, as we know. And you can see that that by the post-pandemic period, they don't have that advantage. And in fact, there's actually sort of lower screening rates among Hispanic adults. So we can look at this again, just looking at the pre and post and excluding that, the triangle that dips down, you can see that for colonoscopies, so if you look at Black versus white adults, you can actually see that in the pre-pandemic phase, white and Black adults had basically the same rates of colonoscopy screening, but in the post-pandemic period, you actually see that there's a relative advantage among Black adults. And not so much the same with Asian and Hispanics. It's difficult to see in this trend, but like if you look at the data, there are some statistical significant declines or increases in the disparities. For fit tests, you kind of see something similar, which is that the Black-white gap, and then that's like really hard to see in this figure here. Actually, it's hard to call it a disparity because they're basically identical, but the Black-white gap sort of shrinks, and the non-Hispanic white to Hispanic gap increases quite a bit. So overall, to summarize, the key findings is there's no real increased use of these non-invasive tests as a result of the pandemic. Although there was sort of a smaller decline during the pandemic closure phase in fit tests, there was not a significant shift towards these non-invasive methods in the post-pandemic phase. And I think that this I'll summarize that on the next slide. But the other key findings is that the impact of COVID risk, it seems like we would have thought that individuals with more comorbidities would be, there would be an opportunity to shift them to the less invasive tests, and we don't see that. And so individuals with comorbidities overall are just less likely to be screened for cancer. We see exactly the same thing when you look at it by age, and we see the same thing in our safety net population when you look at breast cancer screening. We also see the same thing in breast cancer screening in Optum as well. But essentially that older adults, people with more comorbidities, essentially more risk for COVID mortality are less likely to get screened for cancer. And so, yeah, and in terms of disparities, there was sort of a decrease in disparities between Black and white in terms of colorectal cancer screening, and an increase in disparities between white and Hispanic adults in terms of both types of colorectal cancer screening. So the kind of conclusions and implications of this are that we could have. It seemed like there's a missed opportunity here. We could have promoted this non-invasive screening at least as an option for people, and we could have rolled this out. I mean, it seemed like when we were talking to health systems, they were really planning on doing these fit tests, mailing them out, getting them back, but we didn't really see evidence that that's true in the data. And so instead, we sort of created these gaps, and they kind of persisted without catch up. There are some widening disparities, especially between white and Hispanic individuals. And then, I think that enhanced outreach is probably crucial for communities with lower screening rates, like Hispanic and Asian groups. And, you know, we should have more system flexibility to integrate these non-invasive tests to maintain screening during, you know, if there ever were to be future disruptions, we want to think about this. But also, I think just in general, you know, having more options available to people making, you know, these non-invasive tests an option for people who may be, for various reasons, worried about, you know, accessing the health system or accessing these kind of in-person care. Yeah. Okay. And so, yeah, that's all. And take your questions at the end.